Greetings, my name is Mark Galland. I'm an orthopedic surgeon specializing in sports medicine at OrthoNC, Orthopedic Specialist in North Carolina. Today we're going to talk about a newer technique called subchondroplasty. Subchondroplasty is a new surgical alternative. First of all, with knee anatomy, whenever we're dealing with a knee issue, we are dealing with the bones or the cartilage, the meniscus, or other soft tissue structures around the knee. Knee pain often takes many forms. Some symptoms can be chronic, and if so, there may be an underlying degenerative condition or disease, such as osteoarthritis. This degeneration or wear and tear can be part of the aging process, which is accelerated or exacerbated by changes or weight gain, genetics, a history of injury or activity level, or the specific unique biomechanics of each individual. Many of these knee pathologies may be related to a degenerative process known as osteoarthritis. And in many cases, osteoarthritis may be present and compounded by an acute athletic or non-athletic acute injury. Osteoarthritis itself is a progressive degenerative condition. It's very common. There are many radiographic findings typical of osteoarthritis, both on the X-ray and magnetic resonance or MRI images. These can be decreased joint space, bone spurs, degenerative or extruded meniscus tears, subchondral cystic changes, bone cysts, or meniscus tears or deformation of the meniscus, sometimes known as extruded meniscus, or even more recently noted bone marrow edema. Bone marrow edema basically equates to stress-related changes such as stress fracture within the bone. These are fractures that are not able to be visualized on standard X-rays and are only appreciated on MRI images. Most of the current options to treat these either address the meniscus and ignore the rest of the pathology, or are dramatically more invasive, addressing all of the problems, such as a full or a partial knee replacement. Osteoarthritic findings on X-ray are typified by bone spurs, narrowing of the joint, increased bone density, and changes in limb alignment. Bone spurs, narrowing of the joint. There are many options. Conservative treatment is always the first choice. There are many non-surgical options. The two most important options in treatment for osteoarthritis are a low-impact fitness regimen, and it's okay to participate even if it causes pain. You're still encouraged to do so. And maintenance or regaining one's ideal body weight. Periodically, a steroid injection may be useful to achieve these goals. Viscosupplementation, also known as rooster comb or jelly shots. These shots are designed to supplement the body's natural supply of hyaluronic acid, which is the main constituent of joint fluid that helps to lubricate, cushion, and nourish the joint. Bracing, usually to correct limb alignment. Topically applied anti-inflammatory medications. Injectable treatments such as platelet-rich plasma, PRP, or blood therapy. A radiofrequency ablation is a newer tool. It's a pain-relieving tool in which the genicular nerves that surround the knee and are responsible for the majority of the pain sensation in the knee can be temporarily deadened by the use of radiofrequency waves. Oral anti-inflammatory medications or other analgesics are an option, but their chronic use is not recommended. I generally recommend these for brief intervals of 2 or 3 days, certainly not more than a week at a time. Topically applied cryotherapy such as ice can also be useful. If the conservative treatment fails to alleviate the symptoms and one's daily living activities are negatively affected by the pain, we begin to consider surgical options. These include a typical knee scope, also known as arthroscopy, with debridement, which is just a trimming and a cleaning up of the damaged, frayed cartilage or tears. The prognosis is guarded, and most surgeons are reluctant to recommend this if the arthritic changes are moderate or advanced, as the results are not very good. So we're often cautioned in the absence of significant mechanical symptoms such as catching or locking. We often caution against this treatment. Partial knee replacement and total knee replacement. But there's a wide gulf, big difference between just scoping the knee and cleaning it up, which is a minimally invasive procedure with only two or three small fingernail-sized incisions, and a full or even a partial knee replacement. Up until recently, there really hasn't been anything in between that. It's almost an all or nothing phenomenon. Now we have a technique known as subchondroplasty. Subchondroplasty is best utilized in practically only utilized in patients that have subchondral edema or bone marrow lesions noted on an MRI. This is best demonstrated in this MRI image. The bone itself is black on the MRI image. The bone marrow edema is represented by the bright white area. This amounts to a subchondral or below the cartilage stress fracture in the bone. And this is a known pain generator. This is not visible on an x-ray. It is only apparent on an MRI. And these are cracks, or micro cracks, and an attempted healing response in the trabecular bony framework. The trabecular bony framework is the interlacing network of bone struts that comprise the structure of the marrow. Now this model gives an example of normal marrow and what bone marrow edema looks like in this situation. Now, the bone marrow lesions or the bone marrow edema are the source of the clinical symptoms. Now, the subchondroplasty is essentially just an injection, utilizing a very tiny incision in a very tiny hole in the bone with a needle about the size of the typical IV needle. We drill into the bone at the site of the lesion using an X-ray guide and inject calcium phosphate. This calcium phosphate serves two functions. Now, you can see in this model, this previous bone lesion here is now filled with the calcium phosphate. Now, the calcium phosphate serves really two functions. The first function, it acts as an internal splint and eliminates the pain of the fracture by actually supporting and splinting the area. Sometimes the pain can be increased, but if the right amount is used, the pain is usually decreased almost immediately. Secondly, the calcium phosphate provides a matrix or the building block, the struts upon which new bone is formed, and actually the building blocks and the framework. The great news is there are no restrictions. You progress your weight bearing as tolerated, your range of motion is not restricted, and you can begin strengthening exercises immediately. You begin your daily living activities immediately, and they're typically pain-free. And within 2 weeks, most patients have noted a dramatic improvement. We like to limit high-impact or aggressive activities for about 4 to 6 weeks. We use pain as the guide. We don't want to outpace the new bone growth with high-impact level activities.
So Dr. Galland, how would I know if I'm a candidate for this procedure?
Well, if you are experiencing knee pain, we can determine your status by a physical examination. We can further suggest that you may be a candidate with x-rays, which may show some degree of osteoarthritis, and which may lead us to order an MRI. And the MRI would be the final arbiter or the final process in determining your candidacy.
If I've had an MRI and it showed that I have a meniscus tear, what does this surgery do for that?
Well, this surgery is often combined with arthroscopy. So the very first part of the surgery would be a point-by-point detailed diagnostic arthroscopic exam through the same 2 incisions we mentioned earlier. Any obvious pathology and meniscus tears would be trimmed or repaired at that time, and then the bone marrow lesion would be addressed through the subchondroplasty.
How much pain should I expect?
It is a bit variable. Most patients note pain improvement almost immediately. Some patients have a slight or a moderate increase in pain temporarily that resolves within a day or two.
When can I go back to work?
You can return to work as soon as you as soon as you're free to drive, which basically requires no pain medication and the ability to operate the vehicle safely.
How long would I be on crutches?
Highly variable. You may begin advancing your weight bearing immediately, using the crutches less and less each day, and as soon as you can demonstrate a normal reciprocal heel-toe gait, crutches are no longer necessary. This is typically one week.
Will I need to do any physical therapy?
Physical therapy is often not required. A home program is sufficient.
Thank you.
Thank you.